Well, good morning. Welcome to Mitigating the Impact of COVID-19 through Sustainable Health Financing, UHC, and NICC Laws in Focus. It is a vTHD, a virtual town hall discussion organized by Strat-based ADRi Institute in partnership with Citizen Watch Philippines and Cancer Coalition of the Philippines. My name is Paco Pangalangan. I'm the Executive Director of Strat-based ADRi Institute and your host/MC for today. Joining us today are health partners from different government agencies, academic institutions, civil society organizations, patient groups, the private sector, and other stakeholders to discuss the impact of the current pandemic on the country and how to mitigate these effects through sustainable health financing. But before we hear from them, we have to, of course, hear first from Professor Dean Manhit, the president of Strat-based ADRi Institute, to officially welcome you and to open today's discussion. Professor Manhit.
Thank you, Paco. I hope I'm heard and clear.
Yes, we can hear you.
Welcome to everyone, to our health partners, different health stakeholders, and participants who have registered. I know this morning we had over 150 participants for this virtual town hall discussion on mitigating the impact of COVID-19 through sustainable health financing. Of course, this morning we would like to focus on the universal health care and the National Integrated Cancer Control Act. I remember last year, these two laws were passed in the midst of an election season, and right before the start of the election season, we see our champions in both houses of Congress working overtime, pass this law, and even with the president signing it into a Republic Act. And the year after, we are here and we are facing the greatest health challenges of our time. And it reminds me of what I wrote in one of my commentaries in the earlier part of this challenge, this pandemic challenge, when we hosted our first virtual town hall discussion, where I spoke of the healing power of collaboration. The coronavirus pandemic has exposed the vulnerabilities and intricacies of governance, or public governance, and public healthcare system in the country. Here I speak of problems like healthcare facilities and the lack of financial resources. But a few months after, I get to see this report coming from government of this type of allotments, released over 374 billion pesos as of June 30. Then by July 1, I get to see this report by government, again, $5.28 billion of foreign loans and grants from different financial institutions for our COVID response. But today, July 24, I'm reminded of what I saw in the news yesterday. Still, we see cases going up. Active cases is still a substantial number. Happy to see recoveries. Good to hear that there are limited deaths in terms of fatality rate. But it tells us this challenge is here. And I wanted to share our views in Strat-based ADRi Institute. We have always saw ourselves as a bridge between public, the private sector, the civil society sector. And we saw this pandemic challenge as an opportunity to raise this issue of a whole of society approach. It's only through this whole of society approach that we can fight the deadly and invisible enemy. Wrote about this last May 1. This crisis is about saving lives and a rare opportunity to fix our healthcare system. address and institutionalize inclusive and sustained growth, and start a transformation towards good, responsive governance. I speak of our core belief, and today I'd like to share a commentary that I wrote for the Philippine Daily Inquirer. We cannot wait until this pandemic is completely over in order to revive the economy. With public health and the economy in the balance, the way forward is for government to utilize the next year's budget to reform the country's healthcare system, strengthen social protection, and provide a much-needed enabling regulatory environment coupled by transparency and accountability measures. I'd like to leave with these thoughts, participants, speakers, reactors to this morning's virtual town hall discussion. We're so happy to have you, and thank you for joining us, and good luck to us, health stakeholders.
Sorry, I was on mute. Thank you, Professor Manhid, for welcoming our guests to today's vTHD. Always a pleasure to hear from you. First up, we have our first speaker for today. Before I get to that, I just wanted to explain also to everybody that you may have noticed Mark on the screen. He's our interpreter. We have Mark and Jay here, who will be helping some of our stakeholders participate in today's discussion. Also, I wanted to encourage everybody to use the Q&A feature of Zoom if they have any questions, and our speakers will try to answer you either directly through the Q&A or later on during the open forum. So yeah, now that that's out of the way, we can move on to our first speaker. Our first speaker is Dr. Valerie Gilbert-Ulip. Dr. Gilbert is a research fellow at the Philippine Institute for Development Studies. Dr. Ulip is here to discuss some updates on the health system requirements moving forward with the pandemic. Doctor?
Hi, can you hear me?
Yes, we can hear you loud and clear. Welcome.
Hi. Can you see my slides?
No, we cannot see your slides. So there we go.
How about that? Can you see my slides now?
Yes, we can.
So, good morning, everyone. So the title of my presentation is Updates on the Health System Requirements Moving Forward the Pandemic. I'm not so sure if the content of my slides or my presentation will justify the title, but I'll try my best to create a narrative out of my presentation. So there are two major issues or topics that I want to discuss or talk about. So the number one is the macro fiscal context of health financing and UHC in the pandemic and post-pandemic Philippine environment. And the second is the projected requirements for UHC supply side, particularly health infrastructure and human resources. So I just want to emphasize that the second topic is a broader project that DOH and Asian Development Bank are currently working on that I am involved with. So the results are still preliminary, but I think it would be nice to actually share it to more people for comments and suggestions. So I'll start with the cracks in the health system to provide justification on why do we need to discuss this. So I think the COVID-19 really exposed the vulnerabilities of the healthcare system, right? Our ability to control the pandemic is actually dependent on the healthcare system, although the ability of a country to control it is a multifactorial in nature. Like, for example, in Latin American countries, you would see they have a pretty good healthcare system, but because of different factors, they were not able to control it as they want to be. So, but in our context, our readiness to face the pandemic really exposed the weaknesses and challenges of the healthcare system. So basically, these challenges can be, I put them into 4 buckets, right? So there are issues in financing, there are issues in health, human resources, there are issues in service delivery, and issues on governance, right? So in terms of financing, there is chronic underinvestment in health, and I'll show some graphs later. Secondly, there are also inefficient allocation of resources. Over the years, we are spending so much on hospitals and not much on public health. And in terms of HR, there are issues on scarcity of health workers like doctors and nurses. And another issue is the limited professional recognition of barangay health workers. And for example, we haven't recognized barangay nutrition scholars as an important part of the healthcare system, like those things, right? And there's also issues on scarcity of back-end workforce, like ID specialists, for example, yeah, and also there are issues on scarcity on technical experts, like we don't have a lot of epidemiologists, we don't have lots of public health workers compared to other countries like Thailand, etc. And in terms of service delivery, over the years, the system is very hospital centric, right? Which is not actually suitable in a pandemic, right? And there's a weak referral system also, and fragmented ICT. So we've realized that in our reporting systems of cases and mortality and recovery, right? So these are just some of the snapshots of why we're having challenges in facing the pandemic. So, but hello?
Hi, Dr. Uda, we can hear you.
So
Please continue.
So, but I think given all these challenges in the healthcare system, I think there are 4. Hello? So given these challenges, given these challenges in the healthcare system, there are 4 important lessons that the country will learn after the pandemic, which I think is critical. So number 1 is the importance of publicly funded health system. And I think I think that's the institutional legacies of pandemics, right? For example, in Spanish flu, in European countries, and in Russia, for example, they started introducing socialized medicine after pandemic, after the Spanish influenza. So, and after that, we begin to realize that the government needs to spend more on healthcare, and it shouldn't be the private sector who's actually spending for it. And the second is the high regard for public health, right? The country might shift into this narrative that, okay, we begin to spend more on public health and less on hospitals. And third is the shift towards primary care. I think one of the reasons why, for example, a lot of Filipinos do not go to health facility, right? When they have symptoms now, it's because they don't have a relationship with the primary care physician, right? So if I have sniffles or I have slight fever, I don't go to health facility because I don't have that relationship, because we have a weak primary care system. But with this pandemic, we begin to realize that, okay, we need to establish that rapport between the patient and the physician through a primary care system. And the third is the movement to strengthen referral. So now we begin to realize that, a lot of hospitals are actually, congested because of, patients that are mild or asymptomatic. So now the government is trying to reorganize itself. Okay, let's build referral systems and treatment facilities, and bring this patient from hospital to these treatment facilities. And that is the spirit of referral system. And I think that after the pandemic, we might be able to establish that system, right? And again, if you look at these four ideas, is actually the heart and soul of UHC, right? So the mere fact that or the fact that a lot of people are suggesting that we need to delay UHC because of the pandemic, I think it's misguided, because I think the spirit and the heart and soul of UHC might actually solve the problems of controlling the pandemic. So let's start with public spending, right? So in UHC, public spending is critical. No other country that achieve UHC without higher public financing. I mean government as a source of financing. So for example, in Thailand, the source of like 80% of their health spending is public, meaning the government will provide for it. And this is also true in many European countries who've achieved UHC. But in the Philippines, around 35% of the total health spending is actually is public. The rest are private. And I think that the challenge now is actually how do we shift the share, right, from public to private, from private to public. So in the Philippines, we're spending around $40 or $50 per person. The government spends around $50 per person. But in countries that have successfully implemented UHC, like for example, Thailand, they're spending around $200. And Malaysia is also spending the same, right? So both countries are an upper middle income country. We're aspiring to be an upper middle income country. So that should be the benchmark. Countries in Europe that are upper middle are much higher than 200. But I think for us, I think we need to aim for at least $200, similar to Thailand and Malaysia. But the total health spending of the Philippines now, including private, is around $220. So majority are private, but in other countries like Thailand, the share is more on the public. So in terms of per capita spending, you would see that despite in the last 10 years, we allocated more resources on health, right? So adjusting for inflation and population growth, you would see that the per capita spending actually increased from around $20 to around $50 in the last 20 years. But compared to other countries like Thailand or Vietnam or Malaysia, you would see that the increase is actually much higher in those countries, despite the reprioritization that we've done in the last 20 years. So in addition to the level of public spending, I think it's also important to look at how much are we actually spending on efficient interventions, right? So in the Philippines, majority, around 50% of our health spending went to hospital care and very small share for primary care. We're spending around $12 per person in primary care, right? So if you want to shift to a system that's more or is geared toward primary care, we need to spend more on primary care, and we make sure that we're not spending so much on hospitals, and that might just lead to waste or inefficiency in the system. So if the question now is like, okay, you want to actually increase public spending by two, right? Like 2 or 3 folds, like the Thais and the Malaysians. Is it possible to do that given the macro fiscal challenges that we are expecting in the next few years, right? So there are challenges, right? So number one, there will be deep contraction in real GDP growth. So around -2 to -4 this year, and it's expected to bounce back next year. And the second is the decrease in public revenues. So the DUF projected at around 10 to 30% reduction in revenue because of, tax collection because of economic slowdown. So usually in this kind of environment, to address this, there will be like counter-cyclical fiscal policy that will increase debt and deficit, right? So this will actually lead more to economic slowdown that will affect public spending. So I'm going to show you this one. This is a bit complex idea, but I tried to simplify it. So how do we make sure that public spending is actually will increase, right? So public spending for health is a function of three factors. So number one is the health share of public expenditure. So how much of your total government budget is allocated to health, right? The second is how big is your government relative to your GDP? And third is your GDP per capita. So I want to start first with GDP per capita. So if you multiply these three factors, that will be equivalent to your public spending for health. So for your GDP per capita, we are anticipating that this one will decrease significantly. Your GDP per capita will decrease significantly. So if these two will be stagnant, your public spending for health will also decrease. So my point here is that the only way that we can increase public spending now is through reprioritization, meaning that we need to reallocate our resources from other sectors to health sector. The power of GDP per capita that we've been enjoying in the last 5 years, it is not possible anymore. So I think the only way is to actually reprioritize. And reprioritization is actually a political process, right? So it's a political choice that the government needs to make. So how do we do that? So it can be through earmarking again. I'm not sure if that's politically feasible to do more earmarking, and budget realignments. In countries like, for example, Myanmar or Costa Rica, they started to remove their military budgets and shift it to health. I'm not sure if that's possible now, but that's how they're trying to cope up with the pandemic. So I think the pandemic provides a silver lining to do reprioritization, right? So that's actually an opportunity for the health sector, and civil society should be able to ramp up this intervention on how to actually reprioritize. Otherwise, we cannot increase public spending for health, which is important in UHC. So
hi, sorry. Could you wrap up? We are over by a couple of minutes already. Thank you.
Okay, I'll give like maybe 3 minutes. Okay, I'll start. So I think I'll just go through some of the results of the demand and supply side, right? So in the next 20 years, we are actually the demand for healthcare in the next 20 years will dramatically increase by 60 to 70%. Our inpatient care consultation, for example, or inpatient visits will increase around 60%. So how do we cope with that, right? How do we cope with that? Given our current supply of health facilities, is it enough to actually address the growing demand? So here, I'll just go through beds. I think that's the most important, is that currently we have 1.2 beds in the Philippines, right, per 1,000. And in order for us to address the growing demand in the next 20 years, we need to actually increase the demand for hospital beds by twice. We need around additional 1.5 thousand beds per 1,000 population to make it comparable to other countries, right? So yeah, in Vietnam, the number of beds is around 2.5 beds per 1,000. And if we want to have the same level, we need to triple the number of beds that we have. So these are basically the projected supply and demand for different levels of hospitals. I'll just share my PowerPoint because of time limitation. We also have here how many health, primary care facilities do we need in the next 20 years. So basically, and so this is primary care facility, barangay health station, the number of level 1 and level 2 beds. So basically, and this is for CT scan and MRI. So basically, you are so far ahead in reducing the gap in health facilities and health infrastructure. So yeah, and I think for the cost requirement, currently we're actually spending around $32 billion for capital formation, for health infrastructure, for equipment and transportation, and that's around 2.2% of GDP. In order for us to reduce the gap, we need to actually double or increase the government needs to increase this annual spending by more than 2 to 3 folds on top of the private sector spending. So again, the importance of public spending is critical, but the question is, how do we actually raise this money, increasing public spending by twice or thrice in order for us to cope with the growing demand, and in order for us to be comparable with other countries with similar income. So I think that's actually the point. In the paper that we will releasing with DOH and ADB, we actually outlined some of the important ways on how to actually harness that resources and how to allocate it more efficiently, and how do we make sure that these allocations are given to those who are in need. So yeah, that's it. I didn't have much time, but I'll just send to you this PowerPoint for you to see the level of gap and supply, demand for different health facility types, like hospitals, VHS, PCF, etc. Yeah, that's it. Thank you.
Okay. Thank you, Dr. Ulit, for that. Yeah. Yeah. Thank you. Sorry, due to time limits, we had to ping you. The ping means that we're reaching the end of the allotted time per speaker. So let's just quickly move on to the next one. Our next speaker for today is Dr. Eduardo P. Banzon, Principal Health Specialist for Asian Development Bank, who's here to discuss with us health financing initiatives and perspectives on UHC. Dr. Banzon.
Okay. Good morning. Sorry. Too many. Okay. We're gonna control my slides. Okay, somebody's controlling it already. Okay. Great. So I'll try to quickly about interesting topic perspectives on UHC and health financing. And we have the next slide, please. And have the next slide. Okay, so I think we always love to talk about this cube, and what I like about this cube is it sort of simplifies our explanation when we talk about universal health coverage. So it basically means one, and I think Val has basically emphasized this. When we talk about current food funds, can you go back, please? When you look at current food funds, we're not talking about out of pocket. We're not talking about money that comes from the pocket or co-payment. We're talking about, as much as possible, prepaid money. And in a sense, government financing, whether it's done to increase budgetary allocation or which could directly provide for services, or that money goes into an insurance pool or a prepaid fund. And similarly, of course, if we include essentially payroll taxes, that means what you aspire for is to get as much money to get government to allocate much money for health in a prepaid manner. Okay, it's not necessary that is done by it goes to a budget and then it pays salaries or in a sense what we call the traditional way that you understand government budget. It can also be done by having that money, which we are doing right now in the Philippines and in many other countries, to put it into sort of something that's called like a prepaid a protection fund or health insurance fund. So if the more that this blue box, blue cube comes bigger and bigger, then you could easily imagine that it will allow that money to cover more people, that will allow the money to include more to cover more health services. And of course, it will minimize any cost sharing or pocket payment. What's important to understand that this is that when we talk about UHC, it's not just putting money and then paying whatever the provider or the hospitals and doctors wants to charge. It also means that you strategically use the money. Okay, so this is not designed so that whatever is charged, for example, in a hospital admission should be paid, or whatever medicine prices should be paid. You use the power of this money, the purchasing power of this pooled fund, and that's why we have terms like purchasing power and strategic purchasing in the language of UHC, to make sure that the services that you're paying for is the one that's necessary, so primary care, and that you make sure that you get value for money, which basically will lead to lower out-of-pocket. Essentially, what the story of Thailand is that when they put more money into this, they did not just use that money and pay for whatever, because that's more of the story of probably the United States, but they make sure that that money gets best value for the money. And that's UHC. Next slide, please. So I think I basically talk about that. When I talk about UHC, pooling is important, prepayment is important, because that will allow you to do strategic purchasing. That gives you purchasing power. And once you have that, then that will allow you to cover everyone, all needed health services, and that's a nice word, needed, so that you could achieve financial protection. So within the Philippine context, the word needed health services is basically operationalized in what they now call health technology assessments and other studies, because in a sense, needed cannot just be framed on what everybody says, I need that. It's actually framed in policy, in either technical advice to HTA and probably policy decisions, like the cancer law. And it talks about maximizing money to make sure that I'm sorry, I have too many. I'll just stop this. Okay. Okay. My apologies if you keep on hearing the teams. Okay. So it's UHC also, when we talk about pooled prepaid, that you need to sustain that financing. And what we have known is that the best way to sustain that is domestic government financing. That means the money comes from the government. And that is why if you look at the Philippine UHC law, that's the logic. It's going to mobilize lots of government budget, funded in part by the health taxes or the sin taxes, and it looks at this sustained domestic financing to make sure that there's more population coverage. It also means that, you know, if the Philippines wants UHC in a sustained manner, it has to accept higher insurance premium, higher budgetary allocations for health, particular PhilHealth premiums, because those are your mechanisms of mobilizing money to ensure that sustained domestic government finance. We've also seen globally that failure to invest, I think Val has basically highlighted in his slides, that if you don't invest in UHC, then you have problems, including making your country vulnerable to disease outbreaks. And when we talk about underfinanced health system, essentially, logically, you have low health system capacities. Next slide, please. Hello. So what happened with COVID-19? Well, COVID-19 has basically that, in a sense, that if we want to make sure that we want people to have access to what is now deemed as the key interventions for COVID-19, well, the health system interventions, which is testing, treatment services. If our UHC system is already in place, then it's easy for you to ensure this access. Let's talk Korea. When Korea started to say, okay, we want everybody tested. So basically, their private sector rapidly provided the testing because the private sector knew that the insurance system or the UHC system, financing system of Korea, will pay them. And that helped a lot. And India basically did the same story. Okay, they're still grappling with the numbers. But the India, what they now call Ayushman Bharat, basically make a decision to cover everyone who's going to be tested and those that are being treated. Of course, there was a big fight because the private hospitals wants to charge more, much more than what Ayushman Bharat was willing to pay. So we have seen that. So that if your system is not that mature yet, then you'll have problem to immediately guarantee testing for and treatment. And in a sense, it could be reflective of some of the problems that the Philippines is still struggling with. We also know, in a sense, UHC and strong health system are crucial, therefore, if we want to properly respond to COVID. UHC would also, as we are seeing in a number of countries, because we're seeing this phenomena that once you focus a lot on COVID-19, you are crowding out non-COVID-19 health services. The hospitals basically say that there's no more emergency surgeries and all. Much worse on primary care, because a lot of the treatment, for example, for non-communicable disease and all that becomes much more difficult now. You know, it's so difficult now to get consult in outpatient clinics. The difficulty in going to the drugstore. There has been some response, particularly with excellent use of telehealth and telepharmacy and all that. Just makes you wonder why these tools, digital tools, were not adopted before COVID-19. Nonetheless, it's already a big win. And in a sense, UHC system could have contributed significantly if it was in place to reduce this crowding out. And of course, something that, given the challenges that the Philippines is having right now in controlling COVID-19, strong health systems will minimize the mobility restrictions and quarantines, the non-pharmaceutical interventions that are being imposed and will probably be imposed again. So both it's in less and extent if your health system is strong. Why? Next slide, please. People are familiar with this slide, where basically you have this line that says health system capacity, and that the reason you put a lot of the MPIs, non-pharmaceutical interventions, is you want to make sure that your cases do not exceed health system capacity. So if the country has not invested in UHC, how can you, intuitively, your healthcare system capacity would be at a low level. If it's a low level, then intuitively, you have no choice but to impose much more strictly, more stringently, your mobility restrictions and quarantines, because the ceiling or that you're trying to, well, you need to make sure your cases are so low, because anything just above the normal will overrun your healthcare system. So this emphasized, I think, the point that Val was trying to show when he talks about the gaps in hospitals in the Philippines. If your ICU beds are only in the thousands, and we're 108 million, 15 million in Metro Manila, well, just imagine how low our health system capacity is. Which means when we would have, in a sense, government would have no choice but to use the mobility restrictions in a much more, stringent manner. Next slide, please. So ADB, okay, what have we done? The Asian Development Bank. So we have supported developing member countries in addressing COVID. That includes financing, so counter-cyclical support, and basically this funds national COVID response strategies, including health systems, including social protection, loans to businesses. We have done health-specific loans, and we have rapidly mobilized lots of grants and technical assistance. And a lot of this includes sharing of knowledge across countries, getting the evidence, and hopefully respond to some of the health system capacity gaps. Next slide, please. So we look at our support as basically part of the increased financing for the health sector. Okay, COVID-19 has highlighted the fact that there has been chronic underfinancing in many developing countries, including the Philippines. What we have seen in the Philippines is that there's been like at least, I think, at least $1 billion, 50 billion pesos, probably more, additional budget that's been provided for the Philippines to respond to COVID. And this has been done to either budgetary allocations, to the Bayanihan Law, reallocation within the budget, and of course, have increased PhilHealth or health insurance payments. What we should be watching out for is that this would be seen like a one-off, and let's say COVID basically is no longer there, then they will say, come on, let's reduce the financing for health to offset the money that was provided for health. That should not be the way it should be framed. Basically, this new financing should be sustained. I think that this should be the new floor on how much prepaid financing that we provided. And it's a floor, because even if you put 50 billion or 1 billion pesos now, given the numbers Val is showing, that will probably only jump up the 35% to probably less than 40%. Sorry, I don't have the numbers right now. So this is already something, an opportunity that the health sector got. The focus in financing that went to the health sector, make sure that that money becomes the new floor. It does not get taken back next year. But beyond financing, there are other UHC reforms that needs to be talked about, redesign of the health system, harnessing the private sector, use of digital health, HR, strategic purchasing. I can keep on going. But as I would like to finish by saying, COVID-19 has highlighted the chronic underfinancing. The Philippines has done good work in responding to that. Let's make sure that has become the new normal on health financing for the Philippines and its effort to achieve UHC. Over.
Okay. Let's just let our team turn off the presentation and turn off the spotlight for our interpreter so that some other speakers can be seen as well. Well, thank you, Dr. Banzon. Unfortunately, your camera's off, so we can't see you, and thank you in person. But yeah, there you go. Can we see Dr. Banzon?
It's a Friday, so
yeah.
I'm waiting for the hamburger for
Okay, Doc Banzon. Thanks, Dr. Dodo. Sige. Next up, we have Dr. Beverly Ho, who's with the Department of Health, DOH. She's the Director for Health Promotion and Communication Services. Dr. Beverly is here to update us on UHC Act implementation and priorities for 2020. Sorry, Dr. Beverly, you're on mute.
All right. Can you hear me?
Yes, we can hear you, but we'll also be turning off your camera just so that
Sure.
so Jay, the interpreter, can be in spotlight.
All right. Okay. Good morning, everyone. Thank you again for this opportunity to share from the Department of Health. And hello to everyone, especially I think Senator JB's here, who's the principal author of the UHC law. So let us just go back very quickly to the vision of UHC. I understand that all the COVID situation has probably sometimes limited our views on what the health system should or how it should really take care of our people. So we really view UHC as in the UHC law in a more comprehensive manner, that Filipinos are actually able to live healthier lifestyles and enjoy their environments, enabling them to become productive citizens, and also really exhibit good health-seeking behavior and have confidence and trust in the health system. Both of these are, of course, applicable to Filipinos who are not yet sick, no, or who still don't need to access the healthcare system. But when they actually do, they're taken care of by a primary care team who will really look after their healthcare needs without having to go far from their homes and not needing to worry about expenses for their healthcare. So how are we working towards this vision? It is important to note that many legislations have tried to sort of encapsulate how to implement UHC, and they have various focus. But I think it's important to take note that one of the biggest game changers is actually not the law, but the Supreme Court ruling on the Mandanas petition. And this relates to how much of the budget will go into the national government and how much of it will go to the local government. And as the discussions are progressing now, 30%, the ERA is likely to increase by 30%. And that would mean it will be obtained from the different budgets of the national government agencies and directly provided to the local governments. So it is now consistent with what we want in the UHC. So during this COVID response, the entire government adopted this mantra, national government enabled, local government unit led, and people-centered response. And to a certain extent, this was something that the health sector has long been doing or reluctantly been doing because clearly our system is devolved. And however, the budget, the money is not all devolved. Some of it is going through PhilHealth, our national payer. Some of it still with the national government. So I guess with whatever, with the current response, it's become apparent why we actually need to actually operationalize how this is going. And perhaps to say that this is actually consistent with what the UHC law wants, which is to strengthen our province-wide and city-wide health systems. So for 2021, the DOH proposed a total of 184 billion. Our NEP came in last week, National Expenditure Plan, which is just an indicative budget for 2021 at around 120 billion. I wouldn't go into the details of it, but precisely just wanted to show this because whatever policy pronouncement we have, the budget is technically the policy. So most 60 billion of that amount goes to personal services or salaries of healthcare workers, both here at the central regional offices in our DOH hospitals. You'll see here that 74 billion has been proposed for MOE and 50 billion for capital outlay. So for 50 billion here, around 45 billion is actually allotted or budgeted for health facility enhancement program. But what was approved indicatively is around 7 billion, of which around 4 to 5 billion is for health facility enhancement. As for the MOE, the proposed is around 74 billion, and this would include, hospital operations, public health commodities, the national reference labs, and local health system grants. And what has been preliminarily approved is around 52 billion, of which already 33 billion is for hospitals, and around 10 billion would be the medical assistance funds for indigent patients, which we all know is also still for hospitals. And so now you make the calculation of how much of it remains for public health. So as one of the main sections of the UHC law is health promotion, and primarily I am also here to advocate for more efforts for health promotion. And our vision for health promotion is really to empower the next generation to take control of their health. yes, we understand we can focus or we can have interventions for Filipinos of all ages and sizes, etc. But then if we look at what will really be the game changer for a healthier Filipino by 2040, it will be to make sure that the next generation are able to take control of their health. And habit starts when they are really young. So the opportunities we have seen are that first, COVID placed health at the forefront of the public agenda, not just the health agenda. And so it's easier for partners to actually open their doors for the Department of Health. In the past, it would be quite a challenge to get them to notice us, to respond, but then now the heightened consciousness for health is there. And so we want to take advantage of this. And you will see this from all the minimum health standards, guidelines that have been put out by several other agencies as well. And the next opportunity is really looking at digital age. Currently, we still experience digital divide among the older population. But if we're focusing on the younger population, then this should be less of an issue. Just to say that over the next 10 years, our population will grow a little bit older, but still relatively young. And so we looked at the future of health promotion in the Philippines in three lenses, but basically encapsulated by a young Filipino saying, I am healthy because I am empowered. Empowered because he would have the knowledge and skills to develop health promoting habits, live, study, and work in an environment that promotes health, and have access to primary care services and knowing when to seek health services whenever he or she needs it. And this item really links to what Dr. Ulep and Dr. Banson have mentioned in their presentation, that the Filipino needs to have a relationship with the healthcare system, and that relationship will be fostered by a good primary care system. As mentioned, we wanted to focus in the earlier stages of the Filipino life and be able to also prioritize certain risks that actually contribute to the highest disease burden, and be able to empower homes, schools, and workplaces so that they in turn enable the people. No? So we will be working closely with our DepEd and CHED and DTI and DOLE for workplaces. And we're happy to note that because COVID has opened the doors for us, then it should be easier in the coming months and years. So our strategy is anchored on Ottawa Charter's 5 action areas, meaning we will go beyond health promotion campaigns and communication, which is traditionally how DOH has done health promotion. And we will be enhancing our work on health policy. That would be certain legislation, but looking at also increasing self-efficacy through health literacy and community participation. Perhaps I'll just go very briefly to show everyone how do we want health promotion to be operationalized at the local level. So we keep talking about wanting to help out our local government units. What does it actually mean? So we know we have a lot of policies in place, but the challenge has always been implementation. And what we're showing you here is a collaboration between the Department of Health and some of our progressive CSO partners who are working on us with a lot of these health promotion playbook. And basically what we want to show you here is that these are tools for which we are able to assist our local government units in implementing guidelines promulgated here at the central office. It begins with a very simple introduction that's useful to encapsulate the problem, provide proposed interventions which are considered, which have good evidence base and which are considered cost effective, So it won't be a slew of 20 interventions, but really the few that actually works. A very short health policy brief in case the local leaders would want to advocate among their local chief executives. A template ordinance that's already here that they can copy, paste, modify. An implementation checklist that goes through step by step what the local government units can do, be it their local health board or their health promotion officers. An indicative budget plan, just in case they want to implement which of this, so that they know how much they will have to save up or budget for this year or next year. Capacity building module, and also the communication plan, so that it will be very easy for them to sell it to the local stakeholders. No? So we also provided already the draft communication materials that they can modify, and messaging content, as well as an M&E plan. So we will, and frequently asked questions. So we will be coming up with more of these playbooks and work with a lot of local organizations, local academic partners, and civil society organizations, so that we're able to transform one school, one city, one municipality, or even one province at a time. And it won't be a top-down approach, but really enabling local leadership to lead the way. So I guess I'll end my presentation there. Thank you very much.
Thank you, Dr. Beverly. I think, yeah, I think if I'm quiet, our participants will be able to see you a bit. So there, I think, so that's Dr. Beverly Ho from DOH. Thank you so much for sharing your time and insights with us today. Yeah, so thank you, Dr. Beverly Ho. Next up, we have Dr. Clarito Cairo, who is the medical officer and program manager of the National Integrated Cancer Control, including palliative and hospice care and thyroid disorders of the Department of Health. Doc Cairo, hi, how are you?
Yes, good morning. Yes, I'm good. Thank you, Paco.
That's good, that's good. It's good to see you again, po. So I'll give the floor to you, and every now and then we'll be jumping between Doc Cairo and Mark, the interpreter, so that our participants can see who's speaking.
Okay.
Thank you. Go ahead.
Okay, so on behalf of ASEC Nestor Santiago Jr., let me share with you the updates, some updates on the implementation of our National Integrated Cancer Control Act, or the Republic Act number 11215, and our priorities for 2021. So our strengthened National Integrated Cancer Control Program was an offshoot of the cancer law, or the NICC, which was signed last Feb, and the IRR was signed in August 2019. And it was complemented by the signing of the Universal Healthcare Act. The IRR was signed last October 2019. So the two laws will be turning 1 year old next month and in October, respectively. And furthermore, the cancer control program is anchored on our global commitments, namely the World Health Assembly Resolution 70.12 on cancer prevention and control in May 2017, the United Nations High-Level Meeting on Non-Communicable Diseases in September 2018, and lastly, the Astana Declaration on Primary Health Care last October 2018. So Astana is the successor of our Alma Ata after 40 years. So here are the key priorities of the Department of Health as its mandate on the implementation of cancer law and the UHC law. the Cancer Control Division right now is still a work in progress. We will turn 1 year old, and still the division is not yet formally created. The NOSCA from the DBM, we are still waiting for it. But even the interim should have been a good progress. But even in the interim is still not in place. The National Integrated Cancer Control Council, we are waiting for the appointment of our 3 non-ex officio members. The 2 non-ex officio members are already there, Dr. Samuel Ang and Dr. May Dolendo, but we should get all of them on board before we can convene the Cancer Control Council. Right now, it's still for approval of our president. The Philippine Cancer Center will be discussed further by Dr. Melissa Sena later. And the calendar of Cancer Awareness Months, effective this year, 2020, it's already in the DOH calendar. And we can observe various cancer awareness months, which most of them are our priorities as stipulated in the law. The Cancer Assistance Fund. So this Cancer Assistance Fund would be a big help to our patients, our cancer patients. However, it's still a work in progress. Okay, we expected that it will be implemented this year. However, it was not included in the congressional insertion last year, because when the IRR was signed August 2019, the budget was already finished, the budget proposal from the executive department, and through congressional insertion, it will be materialized, but unfortunately it did not. So this, for 2021, we are again hoping and praying that it will be finally implemented. I will talk more about this later. And then the Philippine Cancer Registry will be part of the Philippine Cancer Center. It will be discussed later. Then the cancer control policy in the workplace. This will be a good policy in the workplace because on top of the HIV/AIDS, hepatitis B in the workplace, even tuberculosis in the workplace, this will be additional benefits for the employees on top of the PhilHealth, Cancer Assistance Fund, and even Malasakit Center. This policy will be a big help for them financially and other special accommodations for our employees. The persons with disability, finally, we have oriented the National Council on Disability Affairs yesterday and our regional coordinators on how the cancer patients, persons living with cancer, and cancer survivors can avail the Persons with Disability ID, on how they're going to register and be entitled to the 20% discount and other privileges, and even the non-discrimination. Essential medicines, let's say all medicines, let's say pertaining to cancer treatment, and then including palliative care, our pain relievers like opioids, we need to ensure their safety, their efficacy, and their quality. So health technology assessment would be there to help us on this. And we need to fast track the access of our people to innovative medicines. And finally, the development of the National Integrated Cancer Control Strategic Plan 2021-2025. Originally, the strategic plan is from 2020 to 2025, but due to unforeseen circumstances, it will be adjusted to 2021. So it's still a work in progress, and hopefully by next week we can finalize if the WHO will assist us on this, and if not, then we will just develop it on our own. But we already have the draft and the working document. So we all know that people with NCDs, the non-communicable diseases are more vulnerable to becoming severely ill or die from COVID-19. Indeed, there's a deadly interplay between COVID-19 and non-communicable diseases. And we need to do business as unusual. Since 2010, there has been an underinvestment in the prevention, early diagnosis, screening, treatment, and rehabilitation for non-communicable diseases. The health systems are unable to meet the healthcare needs of our people living with and affected by NCDs. And right now, there's a clear disruption of services for the prevention and treatment of NCDs, which will lead to long-term upsurge in deaths from non-communicable diseases. So the world is at a critical juncture. We need to be forward-looking in our strategies, inclusive of the non-communicable diseases, as required to build back better and to achieve our sustainable development goal of 3.4, that is to reduce the premature mortality from NCDs, including cancer. And finally, we have this Bayanihan to Recover as One Act. Okay, the part 2 of the Bayanihan to Heal as One Act. And I think it will be certified as urgent by our president this week. And hopefully, the said bill will take into consideration this health footprints of pandemic. We have 4 waves. The first wave, which will be the major focus of the said bill, the immediate mortality and morbidity of COVID-19 should be prevented or should be minimized, and including the tail of the first wave, the post-ICU recovery. There have been many studies that all those who recovered from COVID-19 still suffer from the aftermath of the said infection. I haven't read any non-communicable disease in the draft bill. I don't know why, but it should, in order to be forward-looking, they should include the following, the remaining waves, like the second wave, the impact of resource restriction on urgent non-COVID conditions, which include the non-communicable diseases and cancer. The third wave will focus on the impact of the interrupted care on chronic conditions like NCDs and cancer. And finally, the fourth wave, trauma among the patients, the family members, the mental illness as well. It's good that we have the mental health law, the economic injury, that would be a big impact, the economic recession, hopefully not. Then burnout among the healthcare workers and other frontliners. So here's the proposed budget for our Cancer Assistance Fund for next year. And hopefully this can be included in the Bayanihan to Recover as One Act this year. So as you can see, our focus is more on the early detection, which includes the screening for asymptomatic and early diagnosis for the symptomatic, and access to treatment for our patients. So the first one is we need to expand our breast cancer medicines access program and the childhood cancer medicines access program. The higher the budget, the more patients that we are going to help. These cancer meds are not being covered by our field health. Therefore, they are from out of pocket. So we are here to help them minimize their expenses, especially this pandemic time. The early cervical cancer detection using HPV DNA test. This is part of the early detection. The gynecologic cancer medicines access program for the access to early treatment or prompt treatment for the gynecologic cancers like cervical cancer, ovarian cancer, endometrial cancer, even the gestational trophoblastic neoplasia. The medicines are not yet covered by our field health. Early colorectal cancer detection access program. This includes the FIT, the fecal immunochemical test, which we can determine if the patient is positive, then we can proceed to colonoscopy. and the Medicines Access Program for blood cancers like chronic myelogenous leukemia, the non-Hodgkin's lymphoma, and multiple myeloma. They are already treatable, so they can live longer. Our patients. Problem is due to financial constraint, we need to assist them on the budget. So thyroid cancer treatment and surveillance access program includes the radioactive iodine ablation treatment. It's a one-time treatment. It costs 30,000 pesos at Jose Reyes Memorial Medical Center, and it's a big help. It will help the patient survive longer. And the palliative and hospice care medicines access program for all medicines that will help the patient's needs, let's say pain, for nausea and vomiting associated with treatment. So hopefully our partners can help us because last week we were informed that the proposed budget, because these are all part of our tier 2 in the work and financial plan. The tier 1, for your information, was only amounting to 137 million pesos because it's part of the medium-term expenditure plan, which was developed 3 to 4 years ago. And we don't have, the law is not yet there. That is why the tier 1 should be adjusted and the tier 2 should be adopted. That's our wish, our hope. And we need to implement this long overdue Cancer Assistance Fund. And during this time of pandemic, in pursuit of our universal health care, the sustainable development goals, including health security, the global health security, we need to align with the guiding principles and partnerships, especially with our civil society. The local government commitment, especially we are devolved. The community engagement, the health is in the hands of the people, and to deliver as one. Our health system must be progressive, okay? Must be responsive, and most importantly, resilient. And our health services must be accessible, equitable, quality, and integrated so that our people will be informed, empowered, just like Dr. Bev has mentioned earlier, and healthy and safe. So in the context of our cancer control program, we need to strengthen our information systems, the Philippine Cancer Registry, okay? And we need to formulate plans with strong governance and accountability. So that's why our strategic plan, and then to fund priority cancer interventions and ensure financial protection. That's why we have the Cancer Assistance Fund, the PhilHealth benefit packages, and even malasakit centers, as well as the cancer control policy in the workplace. Then we have to build capacity through cancer centers and networks. This is the function of our Philippine Cancer Center, the Health Facility Development Bureau, the Health Facilities and Services Regulatory Bureau. We need to optimize workforce and access to reliable, sustainable medicines and health products. This will be led by our Cancer Control Division and the Health Human Resource Development Bureau. And finally, the partnership with communities and civil society. So we need to achieve the sustainable development goal of reducing premature mortality from NCDs, including cancer. So finally, according to Dr. Susan Rifkin, health services are necessary, but not sufficient to ensure good health for the population. Good governance is essential. And when we say governance, our civil society is part and parcel. So ultimately, our mission is to provide good health to the people through good governance. Thank you very much.
Hi, thank you, Doc Cairo. Next up, Doc, we have Dr. Melissa Sena, who's the interim chief for the Philippine Cancer Center, and she'll be adding a bit more when it comes to the priorities for 2021. Doc Sena.
Yes, good morning. In behalf of ASEC Santiago, I will provide updates on the establishment of the Philippine Cancer Center. So the Philippine Cancer Center is envisioned to be the center of excellence in cancer care, research and development, and capacity development. The objectives, among others, are to oversee the network of cancer care facilities in collaboration with concerned DOH units, and to be the primary repository of all registries in the country related to cancer, and to generate data and analysis to be used for research and to influence policy making and planning. Also to serve as point of contact for international institutions for networking, to continuously improve the center, and contribute to global development in cancer control. Next. So we have developed the resource stratified framework. This was done by the Health Facility Development Bureau of the Department of Health. Cancer is among the 16 specialties for which the HFDB developed framework and targeted DOH hospitals for upgrading to become specialty centers for one or more of the 16 specialties. So according to the resource stratified framework, the specialty care shall be delivered by the specialty centers classified as the National Specialty Center. In the case of cancer, it is the Philippine Cancer Center, and Advanced Comprehensive Center, which have a subnational in catchment, and the regional cancer centers. For the service capability, they are classified as basic comprehensive centers, and then the general care shall be delivered by the provincial, district, and municipality and barangay owned and managed healthcare facilities. This also includes the private health facilities because they are part also of the healthcare provider network. Next. So these are the designated cancer control facilities in the Philippines. For NCR and also the National Specialty Center is the Philippine Cancer Center. And then for the Advanced Comprehensive Cancer Centers, these are the Lung Center of the Philippines, the Philippine Children's Medical Center, the National Kidney and Transplant Institute, Philippine Orthopedic Center, the Jose Reyes Memorial Medical Center, and East Avenue Medical Center. And for Luzon, it is the Baguio General Hospital and Medical Center and Bicol Medical Center. For Visayas, it's the Vicente Soto Memorial Medical Center in Cebu and Western Visayas Medical Center in Iloilo, and in Mindanao, the Southern Philippines Medical Center. For the basic comprehensive centers, these are the target is ideally to have one basic comprehensive cancer center per region. So for Region 1, it's Mariano Marcos, Cagayan Valley Medical Center in Region 2, the Paulino J. Garcia Memorial Research and Medical Center in Region 3, and the Jose B. Lingad Memorial Regional Hospital. Batangas Medical Center for Region 4, it will cover Region 4A and 4B because in Region 4B, we only have the Hospital ng Palawan, but it is still a level 1 hospital as of now. And for Region 5, we have the Bicol Regional Teaching and Training Hospital. And Corazon, actually this is Bicol Medical Center, not BRTTH, Bicol Medical Center. And for Region 6, Corazon Locsin Montelibano Memorial Regional Hospital. For Region 8, Eastern Visayas Regional Medical Center, Zamboanga City Medical Center in Region 9, Northern Mindanao Medical Center in 10, Davao Regional Medical Center in 11, and Cotabato Regional Medical Center in Region 12. We have yet to upgrade a hospital in Region 13 and also in BARM. But we shall strengthen the healthcare provider network and the referral system to enable Filipinos to access specialty care, especially cancer. Next slide. So for the timeline of the Philippine Cancer Center development, the phase 0 is the creation of the interim PCC management office and the determination of infrastructure requirements. We have also developed at this time the development plan and also submitted this to DBM for funding. And for 2020, the establishment of the management office and conversion of the Fabella Annex building into the PCC building. This is located in the Lung Center of the Philippines compound in Quezon City along Quezon Avenue. And then also the capacity building of DOH hospitals identified as specialty centers for cancer care. And then the plan is for phase 2 to establish the research facility attached to the PCC building, and then to increase the capacity of DOH hospitals, specialty centers, and to enable them to conduct more researches for cancer. And then the phase 3, hopefully by 2022 to 2025, is the establishment of a 100-bed or 50-bed hospital for rare cancers with teaching and training capability and capability building of identified cancer care facilities. Next slide. Next slide, please. So next slide. Next slide. Mag-share.
Hi, Doc. You want the timeline for
share.
PCC development or the next
So for
slide? Doc?
For the phase 1 of the Philippine Cancer Management Office, we will show you the next slide, showing the location of the PCC Management Office in the Lung Center compound. Share screen. Share. So this is our location in the orange shaded area. Slideshow. So for now, this is the PCC, but once the USFRAC agreement between Lung Center and PCC is perfected, the Jose Fabella Memorial Hospital will vacate the building, and then the whole building and the 5,000 square meter lot will be for the exclusive use of the Philippine Cancer Center. And then we shall start the development of the area until such time that the 100-bed or 50-bed hospital is established. So this is the building. This is an actual photo of the Philippine Cancer Center, but we are only occupying half of the ground floor because the rest of the building is being occupied by Dr. Jose Fabella Memorial Hospital. But in time, for the timeline, the Fabella requested until November for their complete transfer to the new site, and then the whole building will be turned over to the Philippine Cancer Center. So for now, the interim executive director is Asek Santiago, and I'm the interim chief of the PCC Management Office. We have requested for priority plantilla positions for phase 1, and it has been submitted by the Department of Health to DBM on May 20, 2020 for implementation, I hope, under the GAA 2021. And we have sub-allotted a total of 49 million to the 25 DOH hospitals identified as specialty centers for cancer. So we are establishing the baseline data and integration of cancer registries in the Philippines. We have submitted the terms of reference for the hiring of highly technical consultant for scoping and eventually development of a plan to establish the cancer registry, and then the review of USFRAC agreement between Lung Center and the Philippine Cancer Center. And we have requested for 225 million capital outlay for GAA 2021 for the construction of the research facility. However, we have received the 2021 National Expenditure Program, and our request for infrastructure is not in the NEP, and we have requested for reconsideration because it is a priority project. If it is not given under the Health Facilities Enhancement Program, we requested that the capital outlay for infrastructure is given under the line item of the Philippine Cancer Center. And also, we are in constant coordination with the Disease Prevention and Control Bureau and other stakeholders for the implementation of the NICC. Over. Thank you.
Thanks, Dr. Sena. Thank you for that update on the priorities and for 2021. Next up, we have updates in the UHC Act implementation and funding priorities. Israel Francis Vargas is our next speaker. He's the Senior Vice President for Health Finance Policy Sector of the PhilHealth. Mr. Vargas?
Yes,
You
hello.
have Hypo, you have 10 minutes. We are kind of a bit behind schedule, so I have to remind people now about the time limitations. Thank you.
Okay, thank you. Good morning. Can you please share my presentation?
Sure, we'll work on that right now.
Thank you. Okay, so this is an update on the, as requested as a topic, is an update on the UHC implementation for PhilHealth. And well, I guess some of this actually, all of this actually are as mandated by the, are mandated by the UHC law. And I think some of this actually answers to some of the issues or concerns raised earlier by some of the speakers. So what is the UHC roadmap for PhilHealth? And currently we are actually coming out with the policies, foundational policies, in order for us to implement what is written in the UHC. So with regard to the three areas or the three aspects for example, from the presentation of Dr. Dodo Banzon on the UHC cube, the dimensions, for example, for the population coverage right now is technically we're coming out with the policies on our health information system. It is very important, of course, that all or every Filipino now being a member of PhilHealth is also in our database. So we are also looking for data sharing amongst other government agencies like the Statistics Authority and the like, which are actually also written in the UHC. Our member management with regard to our membership types like the direct and the indirect. And we have actually already have implemented one of the more important provisions in the UHC law right now, wherein every Filipino can avail of the benefit of PhilHealth, no? So we have came out with a circular in 2019, I think it was in sometime in November, for the immediate eligibility of every Filipino, and so they would be able to get all the benefits even if the contribution is not yet paid. We have reminded everyone of the premium schedule as provided again in the law, and this was out in 2019. For the service coverage, we are now, actually we have provided as mandated again in the UHC law to start with our primary care benefit, and we have termed this as consulta. We have came out with a guiding principle sometime in February of 2020 with regard to this consulta, and hopefully we can come out with the accreditation guidelines for the primary care providers, hopefully this August. And this actually sets the motion for our primary care benefit as provided in the as mandated in the law. And of course, others for service coverage would be improvements on the benefit packages. It was, I think, mentioned by Dr. Banzon on the use of the telemedicine and all of those. We are also actually considering it right now on mental health, and of course the palliative and step down care. This was one of this was the topic of Dr. Clark Cairo. And more importantly, of course, is on the financial coverage, wherein we are actually setting the policies right now in making sure that the healthcare providers are now arranged in a system as what was being earlier said by Dr. Val Ulep, uh, we are also uh, putting now the foundational policies with regard to the shift in the provider payment of towards our provider. Strategic purchasing, right now, we are doing these things, and of course, on compliances and still some of those which are identified in the law. Next slide. I'd like to Oh, okay. As a policy agenda, and this is, I think, more important for us with regard to the strategic purchasing. And I think they have stated that it is very important for us now to really make sure that the primary care is being provided. And so we are now having the expansion of the primary care. And in 2021, these are some of our policy agendas. So as I've said, we were coming out with a primary care policy already with accreditation guidelines and on the benefits. It will be part as provided in the UHC law that every Filipino actually should be getting the benefit, and so the member registration to consult the providers so that every Filipino can actually get this primary care benefit. And it is also mandated in the law that with a timeline that in the next 2 years, we should be having a comprehensive outpatient benefit package. And so in 2021, we're starting with several diseases, and in 22, we are adding other conditions, and hopefully in 2023, it is a comprehensive one. And looking down, these are some of the activities with regard to our provider payment mechanism, even the co-payments, which is very important as a part or policy guideline with regard to strategic purchasing. Next slide, please. This is again the some of the activities that we will be having in order for us to shift into provider payment mechanism. The service deliveries, we are now moving towards, of course, rearranging how our health system is, how our services are being delivered through healthcare provider networks. And we are coming out with the policies on the accreditation and contracting process for that matter. And hopefully in 2021, 2023, we can set the phase for initial implementation. So this will now be arranging our healthcare providers into a healthcare provider network with a functioning referral system coming from the primary care up to the apex or to a tertiary level of care. Others, of course, would be some supporting mechanisms to provide incentives like third-party accreditation. Next slide, please. With regard to what we are actually doing right now, also we are responding to the need of the situation. This is the pandemic. Currently, I'd like to just inform everyone that we have our current COVID-19 benefits. We have our COVID for package for testing. We have our community isolation package already. And these are for those which need not be admitted in facilities, but for quarantine and isolation. And of course, we already have our COVID-19 benefit for inpatient. Of course, it was initially termed for pneumonia package because we know that the signs and symptoms initially was for the pneumonia, but we know that this is ever changing, and right now the guidelines there are other symptoms like not only for pneumonia. So we are paying for mild, moderate, severe, and critical types of pneumonia. Next slide. Next slide, please. Back slide, please. One slide back. So these are just some of the stats. And so far, PhilHealth, in its effort to actually provide the support, financial protection during this time of pandemic, we have provided an interim reimbursement to facilities at around 14.7 billion. This is as of July 22. And we have actually provided and processed claims, COVID and non-COVID, from January to as of July 22, around 57.3 billion pesos already. And that is roughly around more than 2 billion pesos a week payment to our providers. And this actually would hopefully make uh, help our providers to go with the current situation, providing them the help and the much needed money and funding for the operation. So we are not just providing for an interim reimbursement, we are continuously paying and processing claims, as I've said. But we all know that, next slide, we all know that the COVID has actually provided us some reasons to facilitate practically the implementation of the universal healthcare. We have seen some learnings from the COVID as a response, technically, for example, on the improvement on the health system, on health delivery, as an example or proof of concept of a whole of government, whole of system approach, which we are actually doing right now because of the COVID. We saw the need really for a functioning referral system and a rearrangement of our provider networks. And so for 2021, technically these are some of our funding priorities. Of course, to continuously provide for the COVID-19 support. And because we are coming out already and launching our primary care benefit, is to support the funding needs for the consulta or the primary care benefit. And it is very important right now, really, that we have to beef up and improve on our IT, especially in preparation for the universal healthcare law. And aligned with the plans of the Department of Health, we are also beefing up on our communication strategies and plans. And this is, of course, in order for every Filipino to know what are their benefits, what are their rights, what are they supposed to do with the under the universal healthcare, what would be their benefits under the universal healthcare coming from PhilHealth, and of course, what are their actual responsibilities. As well, I was not able to provide a slide, but for 2021, our submitted proposed budget for the GAA, this is of course for a premium contribution subsidy, is around 138 billion for the government to cover for the indirect contributors. However, as we have received as a proposed coming from the NEP proposal, or the national expenditure proposal from the DBM, they set to provide us only around 71 billion. I have provided you our 2021, 22, 23, and of course for the cancer, all those are written and all those are also included in the plan. So thank you, and that is currently our roadmap with regard to UHC implementation, especially on the purchasing level. Thank you very much.
Sorry. Thank you so much, Mr. Parga, for sharing those insights. Next up, we have Dr. Corazon Ngalangel. Did I get that right, Doc? The president of the Philippine Cancer Society, who's here to share with us current updates on the Philippine costs in oncology. Welcome, po. You're on mute, so may I please request you?
Okay.
There you go.
Thank you.
Thank you, po. Welcome.
Good morning. Thank you once again for inviting us to talk on Philippine cost in oncology, and this time implications for the National Integrated Cancer Control Act and from the COVID-19 pandemic experience. In 2012, the George Institute for Global Health, University of Sydney, instigated a study of new cancer patients in the ACTION study to increase cancer awareness and inform priority setting, assess the economic and health impact of cancer, provide compelling evidence to the argument for effective cancer control policies, and timely access to affordable treatment in low and middle income ASEAN countries. The Philippines was one of the ASEAN countries who contributed to the ACTION study. And using the Philippine data, We did the Philippine cost in oncology, the so-called PESO study, and described the economic impact of cancer on Filipino cancer patients using the ASEAN cost in oncology study dataset. Baseline, the concept of total pain, total suffering brings together those pain from physical, social, spiritual, cultural, psychological, and financial. Financial toxicity refers to the way out-of-pocket expenses can drain the wallets of cancer patients, poison quality of life, and can be an adverse event of treatment. Financial catastrophe is spending more than 30% of household income for health services after basic subsistence needs have been met. Now, the effective control of suffering requires control of all aspects of suffering within the confines of the clinic to the legislative and public health care policy. The PESO study included a population from PGH, Jose Reyes, and KTI, Veterans Memorial Medical Center, and St. Luke's Medical Center, and they included patients from the pay wards and the charity wards. At the end of the 12-month follow-up period, 26% died, 40.6% experienced financial catastrophe. Cancer illness posed a significant economic burden. Individuals and families became less economically productive. Only 79% received some form of definitive treatment among those who at baseline had planned treatment, particularly among breast and GI stages 1 to 3, and mainly the treatment were chemotherapy and surgery. Now, one of the more important results of the PESO study is that insurance did not have a protective effect on financial catastrophe and death. Now, the predictors of FC and death associated with lower risk are those belonging to the upper income groups, having higher weighted quality of life score at baseline, and having breast cancer rather than GI cancer. Those associated with higher risk were those having stage 4 cancer against those who had stage 1. The non-predictors included sex, age group, educational attainment, having health insurance, and having at least one episode of treatment. Now we look at the insurance. This result, insurance did not have protective effect on financial catastrophe and death. And we look once more at the study population. The 43% were in the lower income group, 40% had no insurance, and among those with at least one form of insurance, where they had PhilHealth, employment-based insurance, private insurance, and community insurance. Insurance has been documented to provide protection against catastrophic illness in other studies, and this was shown in the studies of Healy et al. In China, Cook et al. In USA, Minh and Tran in rural Vietnam, and Kum and Kwon in Korea, noting that financial catastrophe among cancer patients decreased when cancer was included in the insurance coverage plan. Bridenkomp and Bosman did a universal health coverage in the Philippines study looking at progress on financial protection goals. This was for World Bank and in 2015, and they noted that there had not been much progress on financial protection goals in the Philippines over the last 17 years, at least in terms of catastrophic and impoverishing health expenditures. At the time, PhilHealth insurance was at case rate system and covered only admissions, surgeries, and radiotherapy sessions. The breast cancer medicine access program had just begun, and it was just ongoing in limited hospital sites. Now, what is the progress on the national insurance so far? Creation of the SAFE package for illnesses that are likely to lead to financial catastrophe. At the time of the peso study, the SAFE package just started. Now, if it existed at that time, covering all direct medical expenses, it is estimated that the number of individuals who experience catastrophic spending would decrease by 22%. Now came the National Integrated Cancer Control Law, signed in February 2019, and in it is the Cancer Assistance Fund aside from PhilHealth. The Universal Healthcare Law followed 1 month after, and this complements NICC and strengthens the PhilHealth insurance system. The NICC and UHC laws are still in progressive realization. We look at the impact of COVID-19 pandemic in cancer control services in the Philippines. Hospital cancer control services are marginalized during COVID-19 pandemic. There was the diversion of hospital beds, staff, and resources to COVID-19 services. There was closure of cancer-related facilities, OPD consults, follow-up, diagnostic clinics, elective surgery procedures, hospitalization routine procedures, ancillary supports, dental, nutritional, rehabilitation, pain, palliative hospice, and comorbidity management clinics. There was significant reduction of patients coming for the scheduled chemotherapy consults and every 2 to 3 weeks infusion. There was also significant reduction in radiotherapy daily sessions attendance. Only emergency procedures and admissions were allowed. There was significant delay in procurement of needed cancer-related machines in designated DOH cancer centers. There was significant increase in delays of appropriate and adequate treatment, leading to increase in number of disease recurrence, relapse, and progression, with expected concomitant reduction in survival rates. Gains in progress over the years in screening, early detection, and increase in survival were all negated. Lately, the DOH came up with a memo indicating interim guidelines on continuous provision on services for cancer diagnosis, treatment, surveillance, and surveillance amidst COVID-19 pandemic. And this was directed to the LGU, the PhilHealth, the public DOH offices, and hospitals. The local oncology societies, medical oncology, PSMO, surgery, PCS, radio-oncology, PROS, gyne-oncology, SGOP, mainly came up with their own clinical practice guidelines in oncology, considering the COVID-19 pandemic. Now, the community lockdown and quarantine resulted to no public transportation. And if with taxi and private car, there was a need to right of passageway and only one passenger per car, not much family support grouping. There were police checkpoints. You can't enter the locality where your hospital is. Elderly were told to stay at home. Many cancer patients are within this age group. There was inaccessible oncology drug procurement, PCSO, DSWD, oncology drugstores, and pharma drug access program. And there was fear of going to the hospital, so no attendance of follow-up visits, treatment visits. And there was a transition to appointment-only clinic visits, telemedicine, but not all clinics had internet and not all patients can access online internet e-consults. Now, what was the impact of COVID-19 pandemic on the Philippine economy? And this is important because it would also have impact on the cancer services in our country and in our hospitals. The Philippine economy may lose between 276 billion to 2.5 trillion depending on how COVID-19 pandemic develops in the next few months. Metro Manila accounts for 37.5% GDP and Luzon 70% GDP, and these places were under the ECQ at the very start of COVID-19 pandemic. Sectors from retail, real estate to manufacturing are experiencing serious challenges. Over 2 million employees were displaced during the first 5 weeks of Luzon-wide ECQ, wherein about 70% were affected by temporary business closures and 30% employees subjected to alternative work arrangements like forced leave. Metro Manila accounted for the most displaced workers. The Philippine Stock Exchange index dropped by 32% year to date, and government infrastructure program is facing further delays due to ECQ, as well as the repurposing of funds to contain the pandemic. Now, given this background, we have serious challenges in the implementation of the NICC and UHC laws. How much, how deep, how fast, and on the background that we are looking for sustainable health financing.
Thank you, Doc. Maybe you can, thank you for your well-prepared presentation. May we ask you to just hang around for the Q&A? Maybe you can answer some questions later on. Thank you. Now let's move on to our next speaker. Our next speaker is former Senator J.V. Ejercito. Senator Ejercito was the principal sponsor and author of the UHC bill, and was also the chairman of the Committee of Health in the Senate during the 17th Congress when both the UHC and cancer bill were passed. Senator JV, good morning and welcome.
Yes, good morning, Paco. Thank you, Professor Dido Banhit, and to the organizers of this town hall discussion, to StratBase, ADRi Institute, Citizens Watch Philippines, Cancer Coalition of the Philippines. I'm very honored to be invited in this event. It is perhaps the sign of the times, what others are calling the new normal, that we are holding this important activity virtually. The enactment of this universal healthcare law was historic because it represented the first step towards our dream of a genuine universal healthcare for Filipinos. When we drafted the UHC bill, we recognized the need to strengthen our healthcare system and provide our people with a quality, accessible healthcare. There was no global health crisis or pandemic at the time, but we already saw the weaknesses in our healthcare system. When the coronavirus struck our country this year, and when those infected started to overwhelm our hospitals, we saw how strained our healthcare system was. Thanks to the bravery of our frontliners, our doctors, nurses, and other healthcare professionals, they were able to do a fantastic job despite the odds. All over the world, the COVID-19 pandemic has taken a significant toll on people, societies, and governments. Since the crisis began, it was observed that many of our fellow Filipinos who are in need of treatment, such as for cancer, cardiovascular disease, and diabetes, have not been receiving the full health services and medicines they need. The hardship of our citizens to endure to seek health care is unacceptable. Worrying where to get the money to pay for consultations, hospitalizations, medicines, distressed by the lack of adequate health facilities in their area, worried about being infected with illness of other patients while in hot and cramped wards of government hospitals and clinics. The UHC law aims to address these problems by automatically enrolling all Filipino citizens in the National Health Insurance Program and prescribing complementary reforms in the health system. It gives citizens access to the full continuum of health services they need, while protecting them from enduring financial hardship as a result. Last year, I appealed to our fellow lawmakers to fight for the 2020 health budget, mainly intended for the implementation of the UHC law. I will do the same for next year and the following years. I will not allow any delay in the implementation of these laws, since this will be a disservice to the Filipino people. This is a landmark law which should start to benefit all Filipinos. Unfortunately, I'm not there anymore to see its implementation, but I will continue to fight for the implementation of the Universal Healthcare Law. Last June, during the Joint Oversight Committee hearing on UHC Act, I expressed my support for the amendment of the UHC's implementing rules and regulations in order to adapt with the current situation. I gave recommendations to the present legislators, my former colleagues in the Senate, and the House of Representatives on the amendments so that we can strike a balance with the issues in the premium contributions, particularly with the issue of OFW contributions, because as you all know, no law is perfect, no? And probably with this pandemic, it is about time, and it's a good opportunity for us to implement and adjust, no, the law to adapt to the present times. Just as urgent, the National Integrated Cancer Control Act, or RA 11215, signed into law by President Duterte on Valentine's Day of 2019, a few days earlier than the UHC law, addresses various gaps in current cancer care programs, with emphasis on prevention and improving the chances for survival of patients. The law aims to implement integrated solutions from prevention, detection, correct diagnosis, treatment and palliative care, pain management, and survivorship of end life. It aims to institutionalize a holistic and integrated cancer control program for all Filipino citizens. When we were drafting this law, we envisioned a patient-centric, caring, supportive support system with a progressive and an enabling environment so that fellow Filipinos affected with cancer can still live with dignity and enjoy long, productive, and meaningful lives. Similar to the UHC law, I will also appeal to our former colleagues to support the needed budget of the NICC Act. More than a year since the law was passed, it is now high time to push for this gradual implementation. This is my prevailing advocacy as a common Filipino, to see that our Filipino citizens start to benefit from the laws which we help develop. I'm fully aware that the implementation of these laws cannot be done overnight. We need to progressively move forward with urgency in order to realize the objectives of these policies. I'm also aware that the government cannot do this on their own. We need to help each other. We need to listen to one another. Every stakeholder has a role to play, not only for these laws to be realized, but also for the country to prosper. Let us continue to help each other, especially in times of crisis. Let me take this opportunity also as the primary or the principal sponsor and author of the Universal Healthcare Law and Cancer Control Act, the Mental Health Awareness, and other significant landmark laws that were passed during the last Congress. That as chairman of the Committee on Health, I'd like to thank all the stakeholders, the different health practitioners, the health advocates for supporting me, because I could not have done this without your support. I'm not a doctor, but because all of you were there every step of the way, we were able to pass landmark laws that is the biggest step in the right direction in our quest to have a genuine universal healthcare for all Filipinos. Again, thank you very much. Kaya nating talunin ang pandemya na ito kung tayong lahat ay magkakaisa at magtutulungan. Mabuhay po kayo at dalangin ko ang kaligtasan ng bawat isa. Maraming salamat po. Thank you very much.
Thank you, Senator JV. Thank you for also passing all of those landmark laws rather. At this point of the program, I'd like to pass the program on to one of our co-organizers, our partners for this event, Citizen Watch, who's represented here today by Mr. Orlando Oxales. I think Mr. Oxales has a few questions for our speakers.
Yes, good morning.
There you go.
Yeah, good morning. Really glad to see Senator JV again. We were together with the CCPH in really pushing these landmark reforms. Thank you and welcome, sir. And I hope you can help us as we continue this advocacy to put funding to these laws with all of your friends in Congress. My first question is actually an interesting point that Dr. Banson pointed out about the pooled funding. This is something that we have been discussing for quite some time, and maybe Dr. Bansor or probably PhilHealth can actually give us some insight on what would it actually take in terms of funding resources to really realize this 100% universal healthcare for all Filipinos as mandated. Hello? Hello? Dr. Banson still there?
Yeah, I'm still here. I'm sorry.
Yeah.
Sorry if there's background noise. There's actually another meeting I'm joining right now. No, look, one of the things we have seen, not just globally, is that increased government financing, prepayment, let's not use the word government, prepayment usually done by government or regulated by government is necessary for UHC. So different countries have different approaches. Philippines, like most countries, have done basically what we have now called this nice combination. And this is a combination of getting government budgets pooled with premiums, payroll taxes in a purchasing fund. And then government basically focusing more on purchasing because they basically accept that private provision is part of the country system. So this is different from a few countries that basically just get government money, then make the government do the service delivery, and then let the private sector live on their own. Separate reality. So in a sense, the model that the Philippines has adopted is in a sense very similar to Thailand, except that Thailand did not pull in one fund, but basically 3 funds. Indonesia, India, lots of middle income countries right now. It's a model that is very common in Central Asia, Eastern Europe. And in a sense, if you look deep into some of the approaches that European countries did, that's the approach that they did. Very different from the American approach, which basically use a lot of separate pools, health insurance pools. But if you try to understand the Obama law, it was essentially an attempt to create this type of pool as well. So that's already that's it. So it's really difficult sometimes to explain because the Philippines still has this system where you do direct provision, and so as I said, the Philippines looks at the private sector, and here with COVID, we're seeing it now as part of the system. And having a strong government purchaser managing a very huge prepaid pool of money will drive UHC. If people do not want to pay the premiums, higher premiums, if people will prefer that it doesn't go to the purchasing fund, but rather as direct budget to direct service delivery, then you might have some problems. Over.
Okay, thank you for that. My next question would most likely be with Dr. Cairo and Dr. Sena. Dr. Cairo presented a breakdown of a proposed budget for cancer, and Doc Sena actually also presented a very good update on the cancer centers. I'd like to clarify. So would we assume that these two elements have very separate budget proposals?
Yes, sir. Sir Orly, good morning. Separate po silang budget proposal.
I see. And in terms, we are aware that all of these budget proposals are still to be submitted, correct, to the Department of Budget Management?
Yes, sir. Last week, I was informed na hindi po inaprubahan yung 541 million pesos for Cancer Assistance Fund. Hopefully, ma-reconsider pa ng DBM under Sec Wendell Abisado bago pa ma-transmit sa Congress.
I see. That's a little bit concerning. And how about the cancer centers, which is actually from the presentation, is going to play a very important role. What is the status of the proposed budget for that? Doc Sena?
Yes, we have in the National Expenditure Program, we have the MOOE. However, we are still requesting for capital outlay, and it's still for reconsideration. We have submitted our reconsideration to our management because the capital outlay is needed for the establishment of the infrastructure for the research facility. And Philippine Cancer Center is considered as a separate implementing unit of DOH. It is grouped under the line items of DOH hospitals.
Okay, thank you for that. My next question is also related to the budget because we have read in some news reports that there is 35 billion being allocated for the implementation of the new health laws, which includes UHC, NICC, among others. I'd probably like to ask Doc Beverly Ho if there is already a breakdown on how this 35 billion will be allocated. Is Dr. Ho still around? Hello? Is Dr. Beverly still around?
Earlier, I think she left already.
Okay, okay. So anyway, I probably have one more question. This is from Manuel Rojas. He asked, should we reverse the devolution of the DOH so it may have more direct control over healthcare systems as it battles national health problems, such as this pandemic crisis? Would you have any insight on this, Dr. Banzon?
Okay. Sorry. The question is with regards with the devolution, right?
Yes.
Rather than talk about re-centralizing, which unfortunately is probably one of the reasons that the Department of Health has never been able to help local governments do local level delivery of health system. The devolution law has been there since 1991. And in a sense, that's unfortunately, I think it has not been we have not fully implemented that because there seems to be this resistance to that. It's like a lingering resistance. So instead of trying to do it best, there's always this, let's do something else. If you look at the UHC law, it provides a nice solution on how to do it best. That means provisions were put in place to make the local governments work with each other. Provisions is put in place on what will be the job of the DOH, which is policy making, data, and all of that. Among others, provisions is put in place on what PhilHealth should be doing. And rather than talk about that again, I think the UHC law is a well-crafted law. Start implementing it. And this is what we seem to have missed now, my sense, during this COVID, because probably the delay in the implementation, as said by Senator JV, must probably contributed to some of the problems we're seeing right now. So my response to that early is, instead of talking about it again, right? Read the UHC law. It has a very good provisions on how to get the national and local and PhilHealth to work together, and just start implementing it. Over.
Oh, thank you, Dr. Banson. I think we should start a hearing now from our guest reactors. We have a very good panel lined up. First, we have the first author, actually, the first version of the National Integrated Cancer Control Act. The first version wherein we have this law right now was filed by the Honorable Representative Alfred Vargas from the 5th District of Quezon City. Let's hear now the insights from Honorable Alfred Vargas.
Hi guys, good day to everyone. Am I heard?
Yes, loud and clear.
Thank you very much. First of all, I would like to congratulate all the organizers and all the participants here, and thank you very much. It has indeed been a big learning experience for us here. And I would like to greet Senator JV Ejercito and my colleague from House of Representatives, Kong Paul Daza. Much has been said already, so hindi ko na patatagalin pa. I'm here to reiterate my undying support to the public health sector, and as one of the principal authors of NICC, I would like to tell you that we have already engaged DBM and Speaker Alan and chairman of the chairman of the Committee on Appropriations, Chairman Eric, regarding the funds needed for our cause. And perhaps with my co-vice chair of Appropriations Committee, Congressman Paul Daza, we will both work together for the inclusion of the 541 million as Cancer Assistance Fund. And now I learned that we need another 25 million for the capital outlay of our cancer center. And next week, we will be talking with the DBM, and I will make sure that these will be part of the agenda. And you guys are welcome, and you can get my mobile number. Baka meron pa kayong gustong ipasama in terms of budget requirements. So we are here. I'm here to support, and I'm here to fight with you guys. And thank you very much for this opportunity. That's all. Thank you.
Thank you very much. Nice to see you again, Congressman Vargas. Hope you're all well, and we will really count on your support for this advocacy.
Yes, just to note that last year we also made efforts with DBM for a congressional insertion of the 500 million as Cancer Assistance Fund, and the sector knows this. But I think this year we have a bigger chance of actually making it, achieving it, because government is now receptive and is more generous to the public health sector. So best efforts na lang tayo. We cannot guarantee it yet, but I think we have a better chance by this year. And we will never cease to promote and to fight for our landmark legislation, the National Integrated Cancer Control Act. Thank you very much, po.
Thank you very much, Congressman Vargas. We really agree with you because it's pretty obvious that health is in the forefront of the times right now, and it has affected everything, even especially our economy. Thank you very much again. Next, we would like to hear from the Vice Chairperson of the Committee on Appropriations, a very important committee this coming months as the second regular session starts next week. He's the representative of the 1st District of Northern Samar. I'd like to welcome here in our session Representative Paul Ruiz Daza. Welcome, Congressman Daza.
Thank you, Mr. Oxales. Good morning. Can you hear me? Am I loud and clear?
Loud and clear.
Thank you. Good morning, and I'd like to first thank the organizers, Strat-based ADR Institute, Citizens Watch Philippines, and Cancer Coalition in the Philippines. My hello to Professor Dindo Manhit, Mr. Paco Pangalangan, to my colleague, who's also a vice chairman of the Committee on Appropriations. For the people who are watching who don't understand the House of Representatives, the Committee on Appropriations is the committee that reviews and recommends for approval the budget of the national government, which includes Department of Health and other agencies. Also, I'd like to say hello to former Senator J.V. Ejercito and Cara Magsanok Alegpala of the Cancer Coalition. I have an easy job this morning because I was asked to react. And that's what I'm going to do. And to basically summarize what we heard this morning, I would like to emphasize that there are many, many good laws that have been passed in previous years. Just like what was mentioned by Senator JV, the Universal Healthcare Law. We have the National Cancer Law that was, sponsored by Congressman Alfred Vargas. Believe it or not, the last count that we did, there's over 100, almost 180 laws that have been passed in the past that remains to be unfunded. Let me mention, there are other good laws that are health related, other than the mentioned ones this morning. The Magna Carta for health workers, laws increasing bed capacities of various local government hospitals. Recently, the Malasakit bill, of which I was one of the principal authors in the House. So I think to react, I think with the help of the private sector and the community groups, the advocacy groups, I think we need to find a way to inventory all the health-related laws that still remain to be unfunded and advocate with the Senate, the House, and the executive branch to find a way to prioritize the funding of these laws. Namely, as we've been talking this morning, universal health care and the cancer law. Now, having said that, my challenge is, which I'm really happy, which I think Citizens Watch and Strat-based and all of you who are here this morning are engaging legislators like myself and Kong Vargas, because laws require courage and engagement. And it's good that we are talking this morning to find ways on how to empower these laws by putting the right budget. And as mentioned earlier, we will be having a budget hearing soon, within the next 2 to 3 months. And I hope you will keep on engaging all of us. I forgot to say hi to one of my idols, Dr. Banzon with the ADB, who's also, as you may know, a former president of PhilHealth, and Dr. Beverly Ho of the DOH. These are key people who can help us move our advocacies along. Allow me to mention, because Professor Manhit mentioned that this year, 374 billion was released to the DOH by the DBM. But I'm sorry to mention that in previous years, DOH is one of the slow-moving agencies because allocating and releasing budget to an agency is only part of the story. Historically, DOH has had a very low disbursement ratio. In the past, DOH, even though they had the money, you have to realize they have the money, but in many, many years, they don't spend it. They don't disburse it. So that's something I think all of us can take a look at and see how DOH is using the money, if they're really spending it. I support the cash-based system of budgeting, meaning if you're allocated the money this year, you use it or you lose it. Because in the past, the money is allocated, let's say 2019, they don't use it 2019, they roll it over to the following year. So I'm encouraging the stakeholders, the advocacy groups to take a look at this issue and find ways to help DOH use the money faster. Allow me to also support the contention of Dr. Banzon and PhilHealth about using the concept of pooling funds and pursuing strategic purchasing, because it's not just allocating more funds, we need to get more value for those funds. Allow me to also share, because it was mentioned many times on universal healthcare. The IRR of the universal healthcare mentioned no copay. And allow me to shed a little bit of information on this. Universal healthcare for poor people is really meaningless. If you're poor, you go to the government hospitals, because if you have money, you go to the private hospital. So my advocacy is for DOH, PhilHealth, and all stakeholders to keep on pushing, to implement what's already in the law, which is the doctrine of a no balance billing and no out-of-pocket for poor patients. Meaning, if you're a poor patient and you go to a government hospital, whether it's a national hospital like NKTI or a local government hospital, Hospital ng Muntinlupa or Hospital ng Makati, those hospitals, as rightfully mentioned by Senator Ejercito, many of the government hospitals don't have medicines. The lab equipment is not working. There's no reagent. We need to find solutions wherein these hospitals have to function better and to assure that poor patients, and 80 to 90% of them go to our government hospitals, and to find ways where there's no out-of-pocket for those poor patients. And I think Mr. Pargas was here earlier, and PhilHealth is really, I think, the biggest player in this advocacy of no out-of-pocket for poor patients. Because strategically, PhilHealth can crack the whip with all government hospitals, including LGUs, in finding solutions and making sure that the hospitals always have medicines, the X-ray and the lab are always working. Allow me to also comment, PhilHealth mentioned the IRM, which in the past was called global payment, the interim reimbursement model where money was advanced to all our hospitals. So I support that, and I think that's very good that PhilHealth did that a few months ago. And I think I'm hoping to help the hospitals cope with COVID and other operational issues. PhilHealth and DOH should, because DOH is the chairman of the PhilHealth board, I think we should do now a second round of advancing the money to the hospitals this year to help both private and public hospitals. Let me share, before my time runs out, PhilHealth was gracious enough to give me information before this forum. I'm not really sure how how it's going to be relevant, but I wanted to share in case you don't have this information. PhilHealth said that between 2015 to 2019, which is 5 years, case rate, PhilHealth paid 311,500 case rate to patients for those 5 years, totaling 4.7 billion pesos. My initial comment on that, it's probably a little low. Package payments from 2015 to 2019 covered 4,014 patients, totaling 304 million, meaning basically PhilHealth had paid out 1 billion pesos a year for cancer-related cases. That's something we should take a look at if that's enough, and it's probably not enough. My last comment to react, I'm hoping that PhilHealth will work with NEDA and the Philippine Statistics Authority. It was mentioned earlier about their database and IT. It's now more critical to merge all the databases and really work with the Philippine Statistics Authority in solving and implementing what was legislated 2 years ago, which is to provide ID to all Filipinos. We need to do this not just for healthcare financing, which I think will help if everybody is already included in the database, but it will also help in the social amelioration programs. The government has a lot of money, but the problem is it's delayed in getting the money to the right people. And PhilHealth can help in developing the database system, not just for healthcare-related programs, but also for other programs like the DSWD, social amelioration programs. I have other comments, but I'm afraid I might run out. So let me thank all of you for giving me this opportunity. I'm very, very happy that there are people like you who are organizing this. And I think this is consistent with my belief that we need to engage government, including Congress and the executive branch, and in making sure that all these good laws are implemented and fully budgeted. Thank you very much.
Thank you very much, Congressman Daza. We are really glad to hear those words and your commitment in this advocacy. And rest assured, we're joining you to support and really make this advocacy very successful. You actually mentioned a very important point on the importance of data in implementing all of these programs. And that's one of our observations wherein there has to be more investment in terms of technology because for one thing, in terms of planning and budgeting, data is very important. We're seeing right now in this crisis how data is playing a very important role. And it's critical to have information, all of this information, and to be able to efficiently gather and analyze them. Thank you very much, Congressman Daza. Next, we have one of the most effective sectors that are during this crisis. He's actually the head of the National Capital Region and former president of the Federation of Senior Citizens Associations of the Philippines. Friends, please welcome Councilor George Banal. Welcome. Welcome, Mr. Banal.
Thank you very much, and a pleasant morning to all. You know, there is a study that is premised on the belief that the country's senior citizens pose a challenge to the fiscal sustainability of the government's universal healthcare program. In his research paper, Finance Universal Healthcare in an Aging Philippines, Senior Research Fellow Michael Abrigo of Philippine Institute for Development Studies said that the growing elderly population in the Philippines will require more budget allocation for the Universal Healthcare Act in the coming years. Based on the assumptions of the study done by Abrigo, achieving 100% enrollment in social health insurance under the UHC program will require close to 251 billion during the 2015 crisis in government healthcare spending in the year 2020. Raising the share of health costs covered to 70% alone will likely result in public spending estimated to be between 391 billion to 407 billion in the same year. If we do some mathematics, Abrigo says that by the year 2050, the UHC Act fiscal requirements under this scenario is projected to increase to between 361 billion to 604 billion. This translates to about 1.3% to 1.4 annual increase in government healthcare spending to maintain the same level of services that the average senior citizen received in 2015, Abrigo explained. Based on the 2015 data of the Philippine Statistics Authority, there are 7,548,769 senior citizens in the Philippines, or 7.5% of the total population. According to the Statistics Authority's projection, this will increase 11.4% in 2030 and 15.9% in 2045. On the other hand, a 2017 report of the United Nations projected that the Philippines' elderly population will grow to almost 15 million by the year 2050. It must be noted that a huge increase in health spending occurred in the year 2015 by individuals aged 65 years and above. The per capita health consumption grew from 3,100 in 1995 to 12,121 in 2015. Such growth in health spending among senior citizens may be attributed to lifestyle diseases, which include major ailments such as cardiovascular illnesses, diabetes, hypertension, and kidney problems, as well as functional disabilities such as arthritis, rheumatism, and chronic back pain. As a representative of the senior citizens, being the incumbent president of PESCAP Quezon City and NCR, we welcome the Universal Healthcare Act as it addresses two of our major concerns, and they are, number one, the universal healthcare will address the fragmented and overlapping roles and responsibilities of various health agencies. This means that patients, especially senior citizens, will no longer need to hop from one charitable institution to another when in need of assistance. Based on the UHC, the Department of Health and local government units will be responsible for population-based interventions and health services like immunization programs and health promotion programs, while PhilHealth will be responsible for financing individual-based health services. Number two, the universal healthcare is expected to significantly reduce the high out-of-pocket expenditure for health. In 2017, about 54.5% of total health payment came from Filipinos' own pocket, with medicines as main expenditure. Lack of PhilHealth coverage of medicines for outpatients and the high cost of drugs and medicines in the country push the out-of-pocket expenditures up. I would like to conclude my brief reaction with this, our important concern. And so I say, will the government be able to sustain the country's healthcare financing for its aging population, and how? Thank you and good morning to all.
Thank you very much. Thank you very much, sir. It's really glad to meet you. And actually, we at Citizen Watch will be engaging you in some common advocacies that we'd like to work with you with. Thank you very much, sir.
I will be very happy to join your fora anytime.
Thank you. Thank you very much.
Thank
Yeah.
you.
Next, we have the our representative from the Philippine Alliance of Persons with Chronic Illnesses. Please welcome Ms. Liza Martinez, PhD.
Good morning to all of you.
Good morning. Hi, Liza. How are you? Nice to see you again.
Salamat po sa pagkakataon na makilahok sa ating gawain ngayong umaga. Thank you so much for the privilege of being part of and witnessing such a stellar lineup. Thank you for the very rich and diverse and very technical data. And I am here really as a voice for the Alliance of Persons with Chronic Illness and also for persons with disabilities, and of course as a breast cancer survivor. Kasama po namin lahat, sila Cara and sila Paul and everybody else. Just a few quick points to react. When I was hearing especially the talks of Dr. Ulep and Dr. Banzon, this came into my mind and I was struggling with it. I think for us in all of the different sectors which I represent this morning, context is a big concern. I think context from the perspective of particular sectors and context in terms of a historical one. I think sectoral, as you can probably guess, I'd like to mention some points from the perspective of persons with disabilities and the whole concept of visibility. And two particular points that I would like to bring up is visibility in terms of the budget and visibility in terms of participation. In 2013, the Philippine Coalition on the UN Convention on the Rights of Persons with Disabilities did a research to look at national budget and see its compliance to the UN CRPD. And we collected data on best efforts. We were not really researchers and GAA specialists, but we were all persons with disabilities. And from 2007 to 11, we got all the publicly available data and tried to compute how much does the government spend for persons with disabilities. And the top 4 spenders, the first one was actually for health. The others were education, for social welfare, and for national regulation. And just to give you an idea, our research efforts showed that, and this was the only year na nabuo po namin was for 2011, we found that government spending for the entire sector amounted to 0.008% of the GDP. It was about 0.095 of national appropriations that year. And sorry, the 0.008, sorry, my mistake. 0.008% of the GDP was the DOH agency appropriation. The total of the top 4 spenders amounted to government spending of 0.018% of the GDP. I will leave it at that, those figures. The other issue we feel that has really been below the radar or completely absent in the radar is what I have mentioned about visibility. I'd like to take the metaphor of Dr. Ulep about the cracks in the system. Pwede po natin patsihan yung mga bitak, pero pag mahina ang pundasyon, eventually lalabas ulit yung mga bitak na yon. And one of these things is the invisibility of disability and its undeniable relationship to poverty and therefore access to services. And what Dr. Beverly Ho said about budget being equivalent practically to policy is, I thought, very insightful. Despite efforts for the sector on its own to engage in current efforts for the social protection floor and for the social pension, there are still many issues, including for the UHC in terms of the HTA, and determines who gets the attention and who gets what. And participation is thus very key to us, and accessibility. I have been part of the Filipino Sign Language Access Team, and we have been able in the last 4 months made progress that we have been clamoring for the past 3 decades. And we are very grateful for our organizers for having interpreters here right now and giving accessibility to deaf people. Participation is very key to us because the nuts and bolts of the system, which everybody, I'm very amazed that all of the people contributing on their own, as civil society, as government, our legislators, but the voices of people who have lived experiences for cancer and for all of the COVID-19 related as well as the non-COVID-19 related health concerns must be factored into the picture. The weakest link of any national issue will determine the outcome of success. We can succeed in all of the big issues, but yung pinakamaliit could cause all our downfall. So our biggest concern is that right now, all of the efforts and very laudable efforts for the new or the better normal is that it is reactive for the past 4 months. Our sector is struggling with pre-COVID systemic flaws. Dati na po, matagal na, dekada na. Accessibility, 30 years na pinag-uusapan namin just to get interpreters on TV. But the COVID-19 has provided a very compelling backdrop because it's life or death that we're talking about right now. So, yun lang po ang masasabi ko. Just some thoughts in the minds of people, persons with disabilities and those with chronic illness. There are many of them in our alliance. Those with cancer, of course, psoriasis and psoriatic arthritis, epilepsy, mental health conditions, lupus, chronic kidney disease, and many who are struggling right now, particularly because of the national crisis. Thank you very much.
Thank you very much, Dr. Liza. Really glad to see you again, and really love the way you're so passionate about our advocacies. And of course, we will be continuing to work with you and supporting each other in these common objectives. It's very interesting how you really pointed out how this pandemic has even made it more difficult for non-COVID-19 cases, actually. And we've been hearing a lot of reports on the risks of non-COVID patients being sort of boxed out of the medical resources. And that is a real risk that I think it's not being highlighted at this point because of the focus on the pandemic. Thank you very much. Next, we have the president and convener of the Cancer Coalition of the Philippines. They are our partners in this event. We've been partners and in this long advocacy for passing the National Integrated Cancer Control Act. And now we are again working together to finally put some funding, all-important funding to these two landmark laws, the NICCC and the UHC. Please welcome President of CCPH, Mr. Paul Perez.
Thank you, Early. Magandang umaga po sa inyo lahat. And thank you so much for this opportunity. Listening to all the presentations is always enlightening. As Doc Lisa mentioned, nakakalula pero nakakatuwa pati. Okay. So as we all know, COVID has brought a lot of things. It has really put light into the strength and the weakness of our health system. Or as Dr. Ulet mentioned, it showed cracks in the health system. And because it has affected all aspects of our lives, the pandemic allowed patients and patient groups like us a front row seat in observing how our health system works. And in doing so, we were able to realize a lot of things. A good number has been articulated in the morning's discussion, mostly on the underinvestment in the healthcare system. In an era of pandemic, there is a need to further push the idea of no one should be left behind. It may sound cliche when you discuss health financing, but there is a real need to reallocate the budget, specifically to echo Dr. Banzon's point, to ensure reduction of the adverse effects of crowding out non-COVID health services. It is really, from our point of view, it's really hard to embrace the idea that things are not moving on other health issues like cancer or psoriasis, among others, just because there's a pandemic. As I listen to Dr. Cairo, it appears that that is the case. So we hope there is a specific and an assured allocation for NCDs so things will move forward. And when similar situations come in, like another pandemic, I hope not, no sickness or no health condition will be overlooked or worsened just because we have this. There are numerous health laws, as mentioned by Kong Paul, that has been passed, UHC and NICC being the latest. It is good to hear the commitment of the government to fund these laws as shared by Dr. Cairo's presentation. And of course, this was echoed when we wrote the good secretary, Secretary Duque, some weeks back when he mentioned that the health department allocated 540 million for 2021 to enhance existing medicines access programs. He also mentioned, though, that DBM has yet to approve the proposal. I'm not sure if the 10 billion indicative budget shared by Dr. Bev include this, and I hope Doc Bev will clarify this. But because if it's not, then technically, if there's no budget, there is no policy in place, as to use the very words of Dr. Bev. Okay, so if it's not included, we hope the DBM will, and we call on our congressional health champions, Kong Daza and Kong Alfred Vargas, who's been there from the get-go, to ensure this is allocated for cancer, as the NICA law specifically requires that in Section 32, which states that the amount should be in the National Expenditure Program as the basis for the GAA. Having this budget line item will secure the cancer funds will be available, and as not allocating one may bring about bigger health issues, which will put more pressure on the already overstretched health system. The Philippine Society of Medical Oncology shared recently that 85% of medical oncologists experience a decrease in the number of patients seen daily, and 74% of medical oncologists had cancer patients who deteriorated or died because of not being able to seek urgent care in the hospital. In this internal survey, they also shared that the most systemic therapies, such as chemo, were delayed ranging from 1 to 2 or to 8 weeks. These data were gathered just 3 months into the lockdown, and you can just imagine what the figures will be when we face extended GCQ. With no clear budget allocation for non-COVID conditions like cancer, then it would really be worse. There's so much discussion on chronic underinvestment in the healthcare system, so along with the need to have a sustained domestic funding. It would be good to mention, though, that the NICA law signed last year has a very definitive provisions on how to have sustainable funding. In particular, the law allows PPP, or private-public partnerships, and fundraising and donations for the Cancer Assistance Fund, which was not mentioned in any of the presentation. Under Article 3, Section 11, the use of PPP shall be allowed for the procurement of care infrastructure and delivery of services to improve access to and to hasten delivery of essential oncological services. During the times of pandemic, such provision is very, very handy. Also in Article 5, Section 2, it states that DOH may solicit and receive donations which shall form part of the Cancer Assistance Fund, and such donations will be exempted from taxes. Likewise, fundraising activities may be conducted by the council, Cancer Council that is, and proceeds of which shall accrue to the fund and shall exempt from any taxes. All these provisions are included with the sole purpose of coming up with alternative sources of funding in recognition of the magnitude of the cancer problem, which, by the way, is seen by WHO to increase by 81% in a few decades, especially in low and middle income countries like the Philippines, where survival rates are currently lowest. Fighting a life-threatening disease is not just about medicines and treatment. There are so many other aspects to consider. As such, we also want to bring to some attention, admittedly some funding, to Section 23 of NICC, which details the social protection mechanisms, which we hope will come to life as well with a real action plan from DSWD, the LGUs, and even the HMOs. Well, to our minds, let's not add another layer to the uncertainty of our patients. Let's allocate an adequate budget, which is due them, as envisioned in both the UHC and NICC. And I think this is the least that the government can actually do. We look forward to a time when avoidable deaths from cancer will be reduced and unnecessary suffering will be eliminated. Maraming salamat po.
Thank you very much, Paul. Really, I think cancer is one of the problems we have that's being eclipsed by all of this pandemic. And if I remember, the rate of cancer incidence and deaths that we still have is quite alarming. We still have some time for some open forum questions. First, I'd like to ask. This is a comment and a question from Governor Obet Pagdanganan. He says, in Thailand, they have reduced out-of-pocket costs to only 11.77% of THE and focusing on preventive health care. And he's asking what is being done to reduce the out-of-pocket costs in the Philippines. Would our representative from PhilHealth be able to give a response? Hello? Is Mr. Parga still here?
Sir, he's not here anymore.
Okay. Sige. Let's just go to the next question. This is for Dr. Ngelangel. Considering the current situation on how patients are receiving treatments, can we ask what are the current efforts of the PCS in terms of helping engage and on the current, I think the question is, you mentioned the impact of the pandemic on cancer. Can we ask what are the PCS efforts towards this and the current situation and how patients are receiving the treatments?
Okay. PCS, we do have for a long time patient navigation program and helping patients with medicines that are affordable, meaning to say the ones that we could be able to give money to. So during the COVID pandemic, this has been continuing. We still serve the patients. We still gave them medicines that they need. The problem, however, is because of the transportation, they could not come. They could not come to the pharmacy where they usually get. So not many were served, but the program was open the whole COVID pandemic time period, and there were actually also many patients who were able to to get their medicines. But there are also some patients who were not able to do that. Another one that PCS is doing is, of course, is still advocacy. Dr. Rachel Rosario has still been joining the Cancer Coalition on their advocacy activities. So basically, that's what we have been doing for the whole COVID period until now, still providing assistance for medicines and diagnostic needs of patients who come and knock at our doors, and still doing advocacy with the DOH and with the other civic groups.
Okay, thank you for that, Dr. Ngelangel. We have a question from our guests from the Filipino Sign Language Advocacy Cooperative. How would they provide the assistance for deaf customers who need the emergency response and financial assistance? He is a deaf resident with deaf mom and deaf brother from Pasay City, board of Filipino Sign Language Advocacy Cooperative. Maybe somebody from PhilHealth can respond. Oh, he's not yet here? Or he's not here? Okay, there's another question here. I think this would be for either PCS or CCPH. What are the current figures in terms of cancer incidence and mortalities? And can you give us a good overview of what's happening now so that there is some context vis-a-vis the COVID-19 pandemic now that we're now experiencing?
Well, we still don't have numbers really on incidents, and I don't know what you want, but we still have high numbers of cancer patients. Incidence-wise, mortality-wise, cancer still is within the top 5 in the Philippines with the other infectious diseases and the non-communicable diseases. Now, maybe what you want is, given this COVID period, has the mortality risen, or has the stage of the patient worsened? So the answer to has many patients stage of disease worsened? The answer to that is yes, because if you are diagnosed as stage 1, let's say December 2019, and you have not been treated for, let's say, from January up to May, and you only come for treatment in May, then most probably your stage 1 disease could have increased to stage 2 disease, or your stage 3 disease could have increased to stage 4 disease. Now, if we focus on the stage 3 to 4, then the mortality would have gone up significantly. It's very hard to treat a stage 4 disease compared to a stage 3 disease. In stage 4, you have the cancer spread all over the body. In stage 3, it's controlled only on that certain region. So that definitive treatment, surgery, radiotherapy, chemotherapy could have done its thing and could have prolonged the survival of the patient. So yes, that's what I was saying a while ago. The COVID pandemic actually marginalized many of the management of cancer patients, particularly if you're talking about primary prevention, and that is actually screening, early detection of cancers. Many patients actually have not been given due management during the COVID area in coming for their screening procedures, because these procedures are not considered emergency, and hence they are postponed. if you go to a certain hospital during the COVID area, and then you go there for breast cancer screening, they would say it's closed. The screening and is closed because what they're only receiving are emergency cases. So that's what's happening now. We fear that the gains that we had for screening before, early detection before, early and prompt treatment before has been negated. And hence, we would, if you look at WHO pronouncement, actually, we are, there is a fear of what they call a pandemic of cancer, of far advanced cancers, because the early screening and the early detection has been delayed for several months and even up to now, and hence you are looking at a surge of advanced cancer cases. So that's what's happening, and hopefully patients are actually coming back, but in trickles, not dagsa, because as you know, the quarantine is not really fully out. There are still some transportation problems, etc. And hence, it's really more in trickles. But hopefully, within the end of this year, we have full array of opening of all these screening facilities in the Philippines.
Thank you very much, Dr. Ngelangel. Really on that note, I think I'm getting a signal that we are really over time, and probably in just to close this session, I'd like to close this open forum. I'd like to thank all of the actors and the speakers today. As President of Citizen Watch, we are very passionate also with our advocacy to finally see the implementation of these two landmark laws, the Universal Health Care Act and the NICC. And rest assured, we will be giving our full support with all of the stakeholders of these, all of the health stakeholders in seeing and working together with our allies in the legislature to ensure that we will have appropriate, adequate appropriations with this. So with that, I'd like to turn over to our host, Mr. Paco Pangalangan, for the closing. Do we have the photo up?
No, we don't need one of those anymore, Triple O. We've gone.
All right, great.
Yeah, we just do one in post.
All right.
So it's important lang that hopefully everybody smiled at a certain point in the in the VTHD.
Bahala na kami.
Yeah. Okay. Well, anyway, with that, thank you. I'm just here to officially close the event. Thank you, Mr. Oxalis, for moderating the open forums, and to all of our speakers and our reactors for lending some time to us here at ADR Institute, at Chat-Based ADR Institute, Citizen Watch, and Cancer Coalition. We're very happy that we've had a very successful event today. We'll keep in touch. We have many more of these events coming up in the next few weeks. And I hope to see you all again. Stay safe and healthy. Thank you.
Bye-bye.
Bye.
Bye. Thank you.
Thank you very much, Dr. Cairo. Thank you.